Hello, everybody. Welcome to another edition of AFR's EMS Case Studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire Rescue. And today I'm joined by our Medical Director, Dr. Kim Pruitt.
Hi, Chief.
Welcome, Doc. And I am also joined by Paramedic Driver Ben Rubin.
Hey there, Chief.
Thank you for joining us first and foremost. A lot of interesting cases coming out of Station 3. One of the things I wanted to talk about, just because a lot of people don't have experience working at either Rescue 3 or now Rescue 2 or any of the medic trucks, was just how you guys have operationalized having a paramedic driver with a basic officer. And I know you work with a great officer, Lieutenant Clint McPeak. And if you want to just give us an overview of how that's going, what benefits you see from that type of setup.
Yes, sir. I think, like you stated, my officer is amazing, Officer McPeak. And of course, it's great having him for everything fire-related. He just takes over. And then for medical calls, we work together really well. He's super proactive. He'll pull up protocols for me on the way to calls. And then when we're on scene, I think we have a good working relationship where we both talk to each other. When it comes to ALS interventions, I make the final call, but he's super receptive and he saves me a lot.
That's the way it always is with the basics, helping save the medics. That's great that you guys have that partnership. One question that always comes up that before we get into the case is just the documentation piece. How do you guys navigate documentation, since ultimately as the officer, culturally we say that they're responsible for the report, but you are performing ALS skills. How have you guys navigated the report writing part of these calls?
So Clint writes the report, and then typically he's really proactive and he'll have it almost done by the time we get back to the station. And then he'll just ask me a couple questions, depending on the call. Lots of bread and butter calls, he's got it done. But anything ALS, especially 12 leads, he'll just ask me for my interpretation. I'll let him know, we'll talk about it for a second. And then anything more complicated, oftentimes when we transport, I'll be doing the patient care in the back. And so if I have time, I can chart back there a little bit, fill in the holes. And at the station, we just talk about it. I'll read over it once, and then we're both happy with it. We just post it.
Perfect. That's what I wanted to hear, because I knew the good work that you all were doing down there, and I know Lieutenant Podrowski has kind of the same model in the trucks that she's on as well. So just wanted you to share that, and I appreciate you telling us about it. So this case specifically here is in regards to an acute limb ischemia, but that's not what we knew off the bat, right? So Rescue 3, you all were dispatched code 3 to a 28 Charlie, right? A stroke call at a single family dwelling. So talk through what you're thinking when you're en route to a 28 Charlie call. What are the things that you're kind of preparing for before you arrive?
So en route, I'm thinking about remembering my Cincinnati and my Lambs scores. Just remembering, I like to do them all at the same time, do the 4 tests so I can get my Cincinnati positive or negative, and then I can have my Lambs ready. Of course, if we have Lambs greater than 4, I know that we're going to UNM, and that we need to give an early notification. In Station 3's district, that part is always pretty fast-paced because we're so close to the hospital, so I just try to keep that in my mind always if we have something that I'm going to have to send an alert for, thinking about doing that on scene. Other than that, ABC's typical supportive care. We're not going to be giving any specific ALS interventions for strokes, so it's mostly the assessment and the notification that I'm thinking about.
That's perfect. That early notification, especially with those short transport times from 3s, I think is key, so good stuff. So for this particular call, when you arrived, it sounds like you had a 55-year-old male, and you guys found him sitting on his couch. Talk through what you saw when your first patient contact. How did he present to you?
So he presented pretty anxiously, but I could tell, at least in my experience, he didn't appear like he was having, I didn't see any facial droop. I didn't hear any slurred speech. We knocked out the Cincinnati pretty quickly, and it was negative. And he was just complaining about this pain in his leg. So we did an assessment on the leg. We got some history, and it sounded like he had recently had TIA, or what he described it as a stroke that had resolved itself without medical intervention. So we had that in the back of our mind, and then when we assessed the leg, we noticed it was quite pale compared to the other one, and he was just complaining about excruciating pain. I couldn't find a pedal pulse in that leg, and I did feel like it was a little colder than the other one. I had never heard about this as a pathology. I was thinking about DVTs, which kind of present the opposite way, with heat and redness. But thankfully we had our EMS fellow, Dr. Root, on this call, and he was able to come in and call it out.
Offer some real-time education. That's perfect. So vitally stable for the most part, a little hypertensive. It looks like you had a rate of 109. Pressure was 165 over 119, setting 97%, and good respiratory rate, although a little bit agitated. So we started that physical assessment, and we started seeing some abnormalities with the leg that you described. So, Doc, when you're assessing limb complaints, what are some of the things that we should be looking for? Because they can always be very kind of general, vague, like my leg hurts. And it sounds like they use some great diagnostic tools, but what should we be looking for in those types of issues?
So I know when people get ready for like a national registry test or to test out of their EMT basic class or your paramedic class, they always say CMS, pulse movement sensation, is it intact? And it's kind of easy in our head to just say that, but I applaud you here because actually taking the shoe off, taking the sock off, exposing the leg, anytime someone has a complaint of pain somewhere, taking the time to expose the area that hurts and really palpate it, feel it, and thinking about checking a pulse is huge. And the fact that you took the time to do that is probably saved this guy's leg. Because otherwise, if he was just complaining of ankle pain and we didn't take the time to look, he may have ended up in the triage area for hours with ankle pain and some Tylenol, right? But instead you took the time, you felt that it was cold, you saw that it was pale, and there was no pulse, and so instantly that changed his acuity to a true vascular emergency here. And so those physical exam, taking the time to do a good physical exam is hugely important.
So identification is key. You guys were there on that. As far as treatments and interventions, what were you all able to do while you were on scene or in route, or I'm sorry, in transport for the patient?
So we did not ride in the AES unit. They were able to get on scene about the same time we came to the conclusion with Dr. Root. We were just able to establish an IV on scene, and we gave him some fentanyl for pain control. And then the Albuquerque ambulance unit took them code 3 down to UNM, which was good. Just something that, again, I think that part probably would have been missed if we hadn't come to the conclusion with Dr. Root about the severity of what was going on.
Sure.
I think if it was just a pain, typically that doesn't warrant a code 3 response or code 3 return.
Yeah.
Yeah, high index of suspicion as to what's going on. Did it resolve the pain at all, or was he still pretty uncomfortable?
I wasn't around to see the results,
Yeah,
so I was able to start the IV, push the fentanyl, and then he was gone.
He was gone. Okay. So vascular occlusions like this, we have some insight as to what the final diagnosis was, but who in our patient population are most susceptible to these types of occlusions?
Yeah. So with vascular disease, it can really hide, right? And so we know that some risk factors for vascular disease are diabetes, smoking for sure, high blood pressure, and high cholesterol. And a lot of our patients have the myriad of those complaints. It's not often that you see an acute especially arterial occlusion. So atrial fibrillation can do this as well, or some sort of clot in the heart that may be, if someone's not taking anticoagulation medicine for their AFib, sometimes they can launch clots to all different places in the body. Would be one thing I would consider. And it's a good clue that someone has vascular disease if they've had other vascular procedures before. So like this gentleman kind of reported to you maybe a TIA history. Sometimes patients will have a history of a cardiac stent or either other occlusions. It's usually safe to assume that if one vessel is diseased, probably all the vessels are diseased. And then in that case, with those folks that are higher risk for vascular disease, it's always a good idea to check pulses, especially if they're complaining about pain in that area.
Now, So for compartment syndrome, you talked about the 6 Ps. I don't want to put you on the spot. Do you recall those 6 Ps? Can you talk
I
through
do.
them?
This is kind of a pop quiz, but I'll do my best. The big one to remember is actually pain out of proportion to exam. And I'm sure that when you walked up, his leg wasn't swollen, wasn't deformed, the bone wasn't sticking out, and you're like, why are you so upset about this? It looks fine, right? So pain out of proportion anywhere, especially in the belly or in a limb, should catch somebody's attention and make you think this could very well be a vascular problem. Pain out of proportion, poikilothermia, it's a $10 word, it means cold, but it starts with P, so it fits. Paresthesia, so tingling, paralysis, pain, pallor, and pulselessness. And so it's kind of a gradation of the occlusion of the vasculature. You get to the point where it hurts, then it tingles. It's just like if your arm falls asleep, right? Then ultimately the nerve starts to get really painful. Then as there's vascular occlusion, you lose the ability to move, and then it turns cold as the flow is cut off. And so it sounds like this man had all of those things. Needed immediate intervention to restore blood flow.
We love our acronyms in EMS, and I will just be honest, if I was to have poikilothermia, I probably would just make it easier and just say it's pretty cold. That would
Pretty
be
cold.
like
There you go.
But I just keep it simple. So and you guys did a fantastic job. So these cases, right, leg pain, it's kind of vague, it's ambiguous. You guys took the extra steps to do a good, thorough physical assessment to try to rule out. How has that changed your practice? I know these calls aren't, they're not normal calls. You don't go to these regularly, but as far as we talk about vital signs are vital for a reason, a good physical assessment, how have you incorporated that or continue to incorporate that now as a paramedic to explore somebody's complaints further?
That's a good question. I think every call, and especially kind of the low frequency calls, they just added to your bank of knowledge, give you little tools. So I think just getting reps with things like this is super, it's just great. It just gives you a patient presentation that you can associate with an outcome. I also just want to say that it's awesome that we're doing these follow-ups now through UNM RedCap, because I'm probably the primary offender. I'll put in all sorts of stuff because I just like to see, to associate a patient presentation in the field with a pathology that they are ultimately diagnosed with. I think that, we always talk about, STEMI patients have a certain look to them, and the more of them you see, then you start to kind of associate that. So I think this is one of those things where now I have a picture to associate with a disease process, and in the future I think I'll be faster with it.
Absolutely. I commonly use the phrase the Rolodex of experience, but then I realize I have to move away from that because probably 90% of our department has never seen a Rolodex based on their age demographics. So I like the bank, just having the mental bank. And you hit a great point. I think the patient follow-up and feedback from UNM has been phenomenal. I wish we had it with every hospital, so I'm super appreciative of that. You can't send enough of those in because it's a good learner for all of us. Like I review each and every one of those, and it helps me. And the more we get that information out, I think it helps for calls like this, which are typically more run-of-the-mill calls that do have some high acuity, just unknown. So along that lines with the feedback that we got, so we did get some follow-up on this particular patient. What did we find after we transported this patient? He was evaluated.
So this gentleman, unfortunately, what they did find, I had mentioned AFib earlier as being a cause of clots to circulate. They found a thrombus in his left ventricle, which was breaking off pieces and had actually lodged in his femoral artery. And it was a big enough clot to block off 3 arteries to his leg. They were able to go in and remove the clot, but in the meantime, since he had all 6 of the Ps, as they were getting him stabilized for the operating room, they had to do fasciotomies, which is basically releasing the pressure in those compartments to restore blood flow and nerve function before they could get that clot out. Ultimately, he got to keep his leg, so it's a really good thing. Like I said before, if you hadn't caught that, there's a decent chance that he would have sat for hours in the waiting room just as another person with leg pain.
Right.
So it's a great job. Great job checking for pulses and actually doing an assessment on where it hurts.
Fantastic job. Yeah, it can't say enough of just that taking that extra time, a few extra minutes on scene to have that dialogue, do a good assessment is really what led to a good outcome for this patient. So you guys should be proud of yourselves because clinically you did fantastic work for this patient. It's great.
Thank you, sir.
Absolutely. Well, that's all we have for today. If anybody else has some interesting cases, we're really trying to recruit folks to let us know. If you're not as comfortable come and talk with us, that's fine. We'll talk about your case. But I think, like Ben alluded to, this is the only way we get this information out is knowing what other providers are doing, what they saw, what they did, and what the outcomes were. And I think it's just a great learning opportunity. So I'm begging you, give us some more cases to talk about. And until then, we'll see you next time. Thank you.